Hello everyone, welcome to Regeneration Hub Pune. I am Dr. Nihal Devkar, a periodontist, and in this presentation, I'll take you through a different variety of free gingival graft known as Expanded Mesh Free Gingival Graft. There are variety of options to augment keratinized tissue or keratinized mucosa around teeth and implants. Those options being a bically positioned flap either done alone or along with free gingival autograft or in combination with xenogenic collagen matrices available commercially. The long results have been shown to be better with free gingival graft. Now for FGG, it is widely used to increase keratinized tissue. The limitations of free gingival graft being it requires larger graft. When you opt for a larger graft, it creates a large increased donor site morbidity and delayed healing. Now, to address these limitations, few modifications of free gingival graft have been suggested. Those being accordion technique, where intermittent incisions are taken at alternate sides of the graft. Then strip gingival autograft technique, where multiple parallel strips are joined together. Then Akbari suggested a vertical modification of the strip gingival graft, and the recent one in 2023 suggested by D. Grief, that is expanded mesh regeneral graft, which was shown to have a predictable keratinized mucosa gain. In this presentation, we are going to try this technique of expanded mesh free gingival graft. So what is expanded free gingival graft? It is also known as meshed or fenestrated free gingival graft. The concept is that the graft is perforated or slit to increase the surface area, the benefits being greater coverage with smaller graft, better adaptation and revascularization, and reduced morbidity at the donor site. Let's see the comparison between expanded and conventional free gingival graft, which shows that the graft size is smaller in case of expanded compared to conventional. The donor site, obviously, being smaller in size, will be less. Healing speed is faster in case of expanded. The keratinized tissue gain is comparable in both. The aesthetic is acceptable in expanded, while the ideal use can be in larger areas. How much expansion is achieved with these techniques? Accordion technique showed that the length of the free gingival graft could be expanded up to 50%, while the expanded mesh free gingival graft mentioned that the longitudinal expansion could mathematically reach up to 70%. Even if it reaches 40 to 50%, it's a good increase or good expansion. The clinical indications of these techniques are inadequate keratinized tissue or gingiva around teeth and implant, multiple adjacent recessions, implant sites with soft tissue deficiency, and patients with limited palatal tissue availability. Let's see the technique in short, that is what all steps are done to achieve this expanded mesh free gingival graft. First is you harvest a standard free gingival graft of a universal thickness of about 1.5 millimeters. Then make multiple meshing incisions, and finally place the graft over recipient bed and secure it using variety of suturing methods. Few clinical tips about the expanded mesh is to avoid over expanding the mesh graft, to ensure the tight graft contact using suturing methods, and to monitor the shrinkage during the healing period. Different key takeaways from this technique is expanded FGG has clinical, aesthetic, and biological advantages. Literature does support its predictable success, and it is ideal for implants and wide edentulous spans. Let's start with the case. Now here is a case. The patient complains of missing lower front teeth, that is 3-1, 4-1 and 4-2 are missing. There is generalized recession. You can see the recession with upper anteriors as well, especially the canines. There is inadequate keratinized tissue with mandibular anteriors. Once we zoom in, we can appreciate that there is recession with mandibular anteriors. There are few missing teeth, and there is inadequate vestibular depth as well as there is inadequate keratinized tissue. The patient has a history of periodontitis and has grade 1 mobility, especially on the lower left side. So you can see on the incisal or occlusal view the teeth are splinted with a wire splint, and here also you can appreciate that there is inadequate keratinized tissue, there is inadequate vestibular depth. Now coming to the measurement of the recession width as well as the depth and keratinized tissue, it appears to be somewhere around 1 to 1.5 millimeters on both left and right side, while the recession width is quite more, it's around 5 millimeters. The radiograph of the IOPA shows mild to moderate alveolar bone loss with mandibular anterior areas. The final treatment plan includes keratinized tissue augmentation using meshed expanded free gingival graft with mandibular anteriors, wait for the healing 2 to 3 months and go for the prosthesis with missing mandibular anteriors. These are the instruments and materials that are being laid out. Other than the diagnostic instruments, we have kept the BP handle blade, curettes, tissue forceps, gastrovisual needle holder, scissors, hemocol mesh for the hemostasis, normal saline. Apart from the instruments, we have kept variety of suture materials, few resorbable and few non-resorbable ones. Resorbable ones majorly for the apically displaced flap suturing. For the procedure of free gingival graft, we give local infiltration anesthesia on the recipient bed first, on both right as well as the left side, using lignocaine hydrochloride. Then we mark the site on the recipient bed using two vertical incisions and one horizontal incisions. So one tooth extra we are going, that is left side to the right side. Right side we have the canine and we are going to the distal of canine, horizontal incision and then the vertical incision. After this step we are going to do the split thickness flap and raise the flap. We are going to shift the flap apically, which will be called as apically displaced flap, using a 15 number blade. So this is apically displaced flap. You can see the underlying periosteum on the recipient bed. Finally, we suture the flap. This apically displaced flap is sutured using monofilament suture, and this is the incisal view where the flap is sutured and we can see the bed clearly now. We measure the required quantity of the graft, length as well as the height, and we take the template to the palate. We confirm the palatal wall type, whether it is shallow, medium or high. Preferred is high palate, and we mark the incisions on both bilateral sides to obtain the free gingival graft from both left and right side of the palate. To achieve the hemostasis, we use this type 1 collagen sponge, comes in this kind of packaging. The vial is taken out from the packet and it shows that there is hemostatic collagen fiber. Once the vial is opened, we can take out the required quantity of the hemocol prior to the surgery, and once the graft is harvested, we can apply it onto the palatal donor site. Spread it to cover the entire donor site. If needed, we can take the extra material, and both sides, that is bilaterally, it is applied in this case, and the hemostasis is achieved after around 3 to 5 minutes. Once that is done, we shift our focus to the graft that is being harvested, and it is expanded using multiple cuts that are given on kernel as well as the apical part. Also few cuts in between, that is centrally, are given. As you can see in this video, the graft is expanded. This is the second graft that is obtained, multiple cuts given, and the video shows the expansion of the graft. Now we take the graft, put it onto the recipient bed. This is the first graft. Then we put the second free gingival graft onto the right side, and then we start with the suturing of the graft. using a monofilament suture material. We secure the first graft. Now minimum penetration of this graft is done, preferably on the both sides, mesial as well as distal sides, while the rest of the suturing is done on top of the graft using the periosteum or the periostal anchorage suturing. So the first one is mesial and distal side securing, the knots being placed, and we cut the suture material after placing the knots. Now the second graft is being secured using similar suturing method, few to secure through the graft and few majority of the suturing material or suturing is done over the top of the graft using the periostal anchorage sutures. This is the incisal view where you can see tight adaptation of the pregingival graft over the recipient bed. This is the video showing from right side to the left side, the labial view, that the adaptation, and the incisal view showing the adaptation of the graft. Here finally type 1 hemostatic collagen is being used. You can replace it using a fresh collagen to achieve hemostasis, and in this we are closing it using an acrylic plate over the type 1 collagen. We need not remove the collagen. The acrylic plate can be removed in 2 to 3 days, while the sutures from the pregingival graft may be removed after 2 weeks. Thank you. See you soon in the next video.